Welcome to tonight's webinar, Enhancing Sexual Health Care Delivery, Supporting International Medical Graduates in General Practice. We are joined tonight by speakers Dr. Rohan Bopage and Dr. Mahalakshmi Selvanathan. Our GP facilitator is Dr. Natasha Feingold. My name is Jasmine and I am your RACGP representative for this evening. Before we get started, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our presenters for this evening. Rohan is a consultant physician and specialist in infectious diseases and sexual health medicine. His journey in medicine began in Sri Lanka, where he graduated from the University of Colombo. He then gained foundational experience as a junior doctor in the UK's National Health Service before moving to Australia in 2006 as an international medical graduate. Maha is a GP who has a particular interest in sexual and reproductive health, family planning and women's health, and is experienced in providing contraception counselling and safe sex education to schools and community groups. In addition to her clinical work, Maha is a passionate advocate for international medical graduates in Australia and currently serves as chair of the Federal AMA IMG committee. Dr. Natasha Feingold is a GP from Sydney who has recently moved to the Gold Coast, Queensland. She is committed to the quality medical education of junior doctors and worked for many years as a lecturer at the University of Notre Dame School of Medicine. I will now hand it over to Natasha, who will go through the learning objectives for this evening.
Thank you so much, Jasmine. We have a lot to get through tonight, so I might just jump right into the learning objectives. Tonight, we are going to, number one, identify current Australian STI and HIV guidelines that inform testing, diagnosis, prevention, and treatment. We will also describe evidence-based strategies for managing common and emerging sexual health presentations in general practice. We will also apply a patient-centered contraception consultation framework that incorporates shared decision-making. And finally, we'll select and use practical tools, digital resources, and referral pathways to support efficient, patient-centered sexual health care. We're so lucky tonight to have two experts in our field. I will be managing the Q&A box, so if there are any questions that you have during the presentations, go ahead and write them down, and if I can interrupt the speakers, I will, but otherwise we'll also save the Q&As for the end, and hopefully we can have a great chat with our expert presenters. So with that, I'll pass it on to Rohan. Thank you so much.
Thank you, Natasha. It's great to be here, especially as a fellow international medical graduates, and to talk to the general practice colleagues. So what I'm hoping to do over the next 20 minutes, first 10 minutes, I'm going to give you a very rapid update around the epidemiology. Then you'll understand why this is current, what is the relevance. Then we'll go to a more practical stuff around history taking, some of the challenges, how do you make sexual health history easier for you? And also we'll have a quick cases at the end. And I'm going to focus mainly on the male sexual health, and Maha will focus more on the female sexual health. All right, let's start some of the epidemiology. Syphilis. Now, as you know, you probably had heard a lot about syphilis. In this graph, we're showing the data and notification of early syphilis, what is called infectious syphilis over the last decade. As you can see, there's continued to increase, and there's a rapid increase probably starting from 2019. What that actually means, a decade ago, something like a congenital syphilis is extremely rare. People haven't seen it. Now, we see that every year. I mean, this year, again, we have seen a couple of cases already in the Western Sydney as well. So that is a big issue. Babies are born with congenital syphilis, or some are having bad outcomes as a result of increasing number of infectious syphilis. So this graph going to show the difference in the sex-specific infectious syphilis in New South Wales. As you can see, it's largely in men, and in this increase in men, predominantly is gay bisexual men or men who have sex with men, but also, quite interestingly, we start to see heterosexual men also representing increasing proportion. And look at the females, even though the relative numbers are small, and if you look at the notification rate, back in 2015 is 0.5, now in 2023, it almost reached 6. So significant increase in infectious syphilis in female population. So as a result, I think last year, you probably have seen Chief Health Officer in Australia has declared syphilis is an infection of national significance because we are seeing congenital syphilis in this country. As a developed nation, that is a public health crisis. Why? Syphilis readily crosses the placenta and is infect the infant and can lead to fetal death and neonatal complications. So as doctors, I think we have a very important role now in terms of how we curb this increasing syphilis epidemic and having adverse outcomes. It starts with the testing, thinking about how we actually identify syphilis. Majority of the cases, syphilis is asymptomatic, and you pick up on testing, and the testing guidelines has recently been changed. So every woman, when they're pregnant in their first antenatal visit, you should test for syphilis, and we don't stop there. And we'll do another test in the second trimester around 26 or 28 weeks. And also we do another test closer to the birth. And if they are increasing risk, I'll come back to that, we will actually do more testing. So the next slide will show you, this is the policy document from New South Wales Health. As you can see, all pregnant women at the screen at first contact, then we'll do the second contact in the second trimester. But if you have identified increased risk, so what are the increased risks? If the woman has previous syphilis, who had any other STIs in past 12 months, as you know, the same mode of transmission. If somebody had chlamydia, gonorrhea, then they are more likely to have syphilis as well. And over again, when we look up our cases with congenital syphilis for the last 12 to 18 months, then a couple of things comes up over and over again. One thing is the substance use, particularly methamphetamine use, and also associated mental health, drug health issues, and other things like homelessness and etc. These are psychosocial conditions where people become quite vulnerable. And also, if the woman during their pregnancy has new partners or recent partners, or their male partners are gay, bisexual men. These are the things that put that woman increased risk of having infectious syphilis during pregnancy. And you should try and opportunistically test at every occasion because these are challenging cases. They won't necessarily come into the appointments. They might come in for other reason, and you take that opportunity, opportunistically test for syphilis. Let's move on to gonorrhea. So similar to syphilis, we are seeing a much bigger problem now with gonorrhea. As you can, this is in 2015 to 2024, there's steadily increased. There's a dip in where the COVID epidemic happens, but we are continuing to see that. So over the last decade, 2024, we have seen the highest number of notifications across New South Wales. And if you look at actual numbers, they are still on the metropolitan, but relative numbers we see largest increase in far west, northern Sydney, and also western Sydney, where I work. Next slide, please. So this is the sex specific. Similar to syphilis, we are seeing increase in men, and these are largely still gay, bisexual men, but also we are starting to see that in heterosexual men as well. And again, similar to female, if you look at the sex-specific rate, 2020 in 2015 in 2020 was 6, now it's closer to 65, 67. So significant increase start to see in women as well. Let's look at the AMR gonorrhea. So AMR stands for antimicrobial resistant gonorrhea. As you know, gonorrhea treatment, you give in current guidelines recommendation is you give dual therapy, you give half a gram of ceftriaxone intramuscular, and also you give at least 1 or 2 grams of azithromycin orally, depending on the site. So what's AMR referred to? When you see a high level of resistance, MIC to azithromycin, or decreased sensitivity to ceftriaxone, that is, the MIC is creeping above 0.125. So these, as you can see, they are not very common, they are rare, but you will see there are increasing numbers we start to see. And this is 2024, 2023 to 2024 data, but we also start in 2025 data. And also recently, we are also starting to see increasing number of AMR gonorrhea. What is really interesting is azithromycin resistance gonorrhea largely seen in MSM, gay bisexual men. But when you see the effects on decreased susceptibility, that is very concerning because that is our last resort at this stage. They are mostly in heterosexual population. And also, some of these conditions are actually travel related. As you know, when people go travel, people do have sex, and that is the reality. And particularly in our neighboring countries, South Asia, East Asia, Vietnam, Taiwan, China, these countries have a very high rates of Kefraxon decreased sensitivity to gonorrhea. And when they go have sex, they can bring it back to the country and also give it to their partners here. So I think as general practitioners, we are doing it's a really important role because these AMR testing are done by the swabs that you have sent. When you see somebody with gonorrhea, you take a swab and send for culture, and the lab monitor that. So that swab is really critical part. If you don't send it, actually, we are not going to find that out. Unfortunately, since the Trump administration, what has happened is there's a lot of funding cuts, and our neighboring countries, particularly Vietnam, China, and Southeast Asia, their surveillance program has been stopped. So we now really don't know what's happening in our neighboring countries. And only way to find out is keep up with the programming, the surveillance at this stage. Let's look at Mpox. So Mpox, previously we used to call monkeypox. We now can not use that word monkey because it's stigmatizing. So please use the word Mpox. So it's a viral illness. And last couple of years, in 2022 and 2024, we saw quite a big outbreaks of Mpox. So there are two types of Mpox. What is endemic in Africa, that is clade 1. What we're talking now in Australia and some of the other developed countries is clade 2. And there has been a quite an increase in 2024 and 2022, but due to the vaccination rates, the rates has now come down. But still, we start to see Mpox, and anybody can get Mpox, but still, we see largely concentrated on gay bisexual men, and also we start to see some heterosexual, particularly around sex workers. And it is a self-limiting illness, but in some people, sorry, go back to the slide, sorry. It starts with the prodromal symptoms like fever, fatigue, lymphadenopathy, then develop quite a painful, people describe as rash, then it turns into blisters and then ulcerate. And these lesions can go on for sometimes 2 to 3 weeks. And there are some complications, but they are rare. And testing is very easy. When you see something possibly related syndrome, you take a dry swab and then send it to the lab and they have a multiplex testing for Mpox. Next slide, please. All right, I only have one slide. HIV, this is like a 1 hour lecture that I normally talk about. But HIVs, I mean, Australia is leading the world. We are actually trying to come to a stage in the future that we might have a virtual elimination. So you will see our numbers are coming down. But in epidemiology now, we are starting to see some shifting happens. So those who are born in Australia, who are connected to the community, connected with the health seeking behavior health service, we see less and less HIV. The more HIV we now seeing people are overseas born, particularly overseas born gay bisexual men who come to this country not engaged for various reasons, stigma, religion, culture, etc. They are not engaging, they are not on PrEP, they are not getting the messages, and they're the one who's getting HIV. Other group are those who are migrated from other countries, and particularly late diagnosis of HIV who end up having complications. They are probably acquired HIV in their home country, but never get tested until they become really advanced, and sometimes, unfortunately, end up having horrible complications. So this is the changing on epidemiology. Think about that, particularly those who are working in regional and rural general practice. You might have these patients with you. They might not come out to you and say, I'm gay, I'm bisexual, I have sex with men, or I use drugs and have multiple partners, or I go overseas and condoms sex. They're the one now getting HIV. So I'll come to PrEP about that. I think PrEP and also large uptake of HIV antiretroviral treatment has changed the dynamic of our epidemiology. So next slide, I'm talking about PrEP. So PrEP stands for HIV pre-exposure prophylaxis, highly effective. If you people take it properly, we are talking about high 95 to 99. Essentially, people who take it properly, they don't get HIV. So this is what we are seeing, particularly in metro cities. So if you take the Sydney, southeastern Sydney, in the Western countries, gay bisexual men who are on PrEP don't get HIV anymore. And Australia has done incredibly well in terms of PrEP uptake, but there are a lot more work to do, particularly for you as a general practitioner. Sexual health services alone cannot do that, particularly in the regional, rural, and non-metro areas. There are people who benefit from PrEP, and that will change our goals to our HIV epidemiology, probably virtual elimination. And PrEP is easy to do. You manage lots of other complicated diseases. It's very, very simple to do. PrEP is, you don't need special accreditation. Any general practitioner can prescribe PrEP. All right, in the interest of time, I'll just quickly move into the next topic. So about STI testing. So there are two groups of testing when you do. So you test somebody when somebody present with symptoms, signs suggestive of an STI syndrome. Other big and important group is you test somebody when they don't have any symptoms, but you do opportunistic testing. So I have highlighted some of the symptoms that is in your primary care STI guidelines. The link is there where you have anogenital lumps, ulcers, other symptoms like rectal symptoms, especially as a pain, discharge from the rectum, or vaginal discharge, or other conditions like the rare ones like a sex-associated diarrhea. People start to have like sugar. So in these cases, you do test because person have an STI syndromes. And depending on the condition, I'll talk about what sort of testing you will do when we talk about the case studies. But the really important thing, what I want to talk to you about the screening. When the person comes in for something else, they are well. If they have any of these other risk factors, it is a really good opportunity that you should try and do testing. Who are these at-risk population? Our Aboriginal and Torres Strait Islander people, then you have sex with men, sex workers, people use drugs, particularly people use methamphetamines, gender diverse people, people being in and out of prisons, or people come from high-power countries. Another important thing, as I mentioned in gonorrhea, the travelers and also people mobile workers. Sometimes they do fly in, fly out like workers, and they do maybe have engaged in sexual activity there. Sometimes they go back to different countries. And finally, again, important thing we talked about pregnant people. All right, next slide, please. All right, couple of things when I go into sexual history. I'm running a little bit time behind. So these words can be called terminology, can be confusing. So in this context, what does sex actually mean in here is the physical sexual characteristics. So when a baby is born, they'll be assigned to either man, a female, a male or female, and comes out they might have a ambiguous genitalia or might have both male and female, they will be intersex. Gender is very different to sex. Gender is how you expression yourself, your identity, sense of self, where your masculinity, femininity, and some people identify it as non-binary. It could be both. And according to that, they might use particular pronouns, he, she, they, other. And sexuality also very different to sex gender because it is how you attracted to what is your sexual attraction. Is it more masculinity, people or with the feminine people? And they might identify as gay, straight, queer, bi, and there might be different other terminology. And again, when you talk to sexual activity, that's also quite different. Uh, for example, one person might be assigned sex as a man, identify self-pleasure as a female, their pronoun may be they, and they might be saying they're queer or bi or straight. In their sexual activity, they might have a vagina or they may have go and change the gender assignment surgery and might, instead of having a penis, now has a vagina. They might have vaginal sex or they might not have vaginal sex. They might elect to have anal sex. And also they use sex toys and also the word chemsex. They might use some drugs during sexual activity that will enhance their sexual and also makes them more risk to STIs and HIV. Next slide, please. All right, sexual health history taking. So as an IMG, I think we all kind of dreaded when we come to sexual history, but I would like to assure that you, as a general practice, you've done a lot more complicated discussions. So when you come to sexual history, if you follow a pattern, and if you do some practice, this is actually quite easy. So important things, how I do, I start with the confidentiality and privacy. So every time I see a patient, first thing I'll say in Australia, there's a very good privacy laws to protect your confidentiality and reassure the patient, and that will make the trust and make the patient comfortable. Other important thing is be mindful about your body language. If you're not comfortable, patient will pick that up, and it's not going to go very well, and probably you might not be able to do a good job. And also how you normalize that. That means you will say the same thing and say, I'm going to ask some very personal questions. The reason I'm asking these questions determine what I'm going to do, what sort of a test, and going to help me, and I'm going to help you to find out what's going on. And I'm going to ask this question everybody and also tell that these are common conditions. There's nothing shame about it, doesn't define who you are. And most of the STIs have no symptoms. If I don't know what test to do, I'm not going to find out. And most are treatable, and majority are very curable and managed very easily. So don't make any assumptions because most of the time you will get it wrong if you make assumptions. And also, we all have our value systems, our attitudes. But when we come to these conversations, in any conversation in medicine, I think we have to set this aside and have an open mind and put the patient in their best interest. So the way I do, I go back to when was your last sexual contact? And then I'll ask a little bit about, is that with a man? Is that with a woman? Or is it with a group sex? Or is it a trans person? And what sort of a sex did you had? Was it oral sex? Or was it deep kissing? Did you have anal sex? Or, and especially if you're two men and woman, when you talk two men, I'll ask whether you're top, bottom, are you inserting or receptive partner? Was there ejaculation? Did you use condoms? Or did you use drugs? Or etc. etc. And there's a really good section around STI guidelines that you can see in here. And this section actually came directly from here. So the take-home message here, if you practice have your own way of systems and then use the same thing over and over again, and you will do it very well. And there's no hard and fast rules around it. Time practice. This is the way that I started. This is where that when we in clinics, how I teach to my juniors. Next slide, please. I'm nearly there. All right, last slide. So we have 4 cases, but they are very rapid cases. I'm not going to spend too much time around each, maybe 1 or 2 minutes. So what I'm trying to do is, in these 4 cases, I want to think what are the DDs, what tests, and what treatment you're going to do. First case is a Jake. It's a young 26-year-old Aboriginal man who identifies as gay, come to you with the urethral discharge. He's saying discharge is like a greenish. So one of the most common DDs here is gonorrhea, chlamydia. Obviously, there are a lot of other things. So what is the important thing I mentioned here? This is you need to examine the person. When you see the discharge, you take a swab for gonorrhea culture, remember, and you do a first pass urine for chlamydia gonorrhea. And you won't stop there because he identifies as a gay man. So he might have oral sex, anal sex. You need to swab their pharynx and also anus. And what about serology? So HIV, syphilis, very important. And also hepatitis B, don't forget about that. And then in this case, what test you have talked about, then what the treatment empirically you will do, you will give a ceftriaxone, azithromycin. If you're thinking maybe have a co-infection of chlamydia, you might give doxycycline as well. Next case, Mike. Mike is 55-year-old man. He identified as a straight, and he comes, he's very embarrassed. He got something in his bottom. He got multiple lumps. And when we see those patients, these straight men who have something up in their bottom, it's really embarrassed. I think it is quite a stressful conversation to have. I think it's important to reassure you don't need to have anal sex to get things in one one because this is proximity area. If you get some infection elsewhere, it can easily spread to your perineal area. This could be warts, could be herpes, could be many other DDs. So I think in this case, what I really want to highlight have that to reassure that person. Particularly, we see over and over again straight men avoid coming to the clinic, see their doctor. They get labeled as gay men or having sex with other men or having anal sex. So it is not the case. Next case is Ree. She's a 32-year-old identified as a trans female, and she comes and says, I got a penile rash. So again, trans female, to understand some of them have a penis, some of them have a neo vagina, and some of them even though have elected to have vaginal sex or may have anal sex. So in this rash could be very different people. So that's why examining is really important. In this case, the rash is a very painful ulcers. Most differential diagnosis is herpes, mpox, And sometimes even syphilis, even though classically they are painless, it could be syphilis. Last case is Ramesh. He's 42-year-old man. He's identified as straight, but occasionally he go and have sex with men. But it's a very rare occurrence, and he identifies I'm a straight man, and he want to know about PrEP. So what do you do? As it's really good opportunity for you to talk about, because these are the people now we are getting HIV because they are not connected, they are isolated, they are stigmatized, they are not reaching out, they are not on PrEP. So it's asking question about what sort of sex when you're having anal sex. Do you have anal sex? Or where do you have sex? And what sort of risky sex? And the PrEP again, as a general practitioner, you can easily provide PrEP. And there are ways to take PrEP what's called on-demand PrEP in certain conditions where, particularly like Ramesh, where not having lots of casual sex, occasional sex, he could do sex PrEP on demand where you take 2 tablets before at least 2 hours, then one 24 hours, one 48 hours. So again, I'm just going to highlight in my last minute, there are a lot in general practice that you could do, particularly these are challenging cases. And if you apply the same principle and have a non-judgmental attitude, you'll be able to get a history and identify what are the tests you will do and offer treatment and also preventative methods. Thank you. I'll stop there and then hand over to Maha. Thank you.
All right, thank you. So maybe we can move to the next slide. So look, when I first started in general practice as an international medical graduate, I wish I had understood just how broad our human sexual and reproductive health truly is. So, I come from an Asian country, so it was quite mind-blowing. So people have sex across entire lifespan, from very young adult right through to their 70s, 80s. No, they have sex. People have sex. That's normal. It's our responsibility to ask without judgment and listen without assumption. I had, termination of pregnancy is a patient's choice. It's not a moral debate. Our role as general practitioner is to provide accurate information, compassionate care, support, even though our personal beliefs differ. Now, not all vaginal ulcers is sexually transmitted infection. And if you anchor too quickly, it will lead to misdiagnosis and broken trust. Now, we've got really one of the best cervical screening program in the world. And, you need to know how to explain it clearly and respectfully. It's vital, especially for patients that are coming with fear, with trauma, cultural hesitation. Now, a patient's sexual orientation is their choice to disclose. It's not ours to presume. And yes, like same-sex couples can and have to, they do have babies in many different ways. Now, probably go to the next slide. So like Rohan said, I think one of the hardest things for new doctors, especially IMGs, is knowing how to start a conversation about sexual health. Now, the key is to raise it at any opportunity. Make it feel normal. Don't make it feel awkward. Okay. So I usually have a simple hook, like a single neutral sentence that opens the door. Sometimes I just tell my patient, look, I ask all my patients this because it's an important part of your overall health. And that one line is enough to reduce the stigma. It gives the patient permission to speak. Now, sexual health discussion doesn't have to sit in isolation. They can come naturally as a part of any other consultation. It can be during a reproductive consult, mental health consult, contraception, fertility, alcohol, drugs, anything. All these overlap with your sexual well-being. Now, sometimes if you're lucky, it's quite straightforward. The patient may directly ask you, can I have an STI screen? So when that happens, it's our job to respond calmly without surprise or judgment. You create a space where that honesty feels safe. Okay, so when you start normalizing conversation, patient starts opening up, and that's where good medicine begins. Now I'll move to the next slide. So, as I said, this is the same thing. Easiest way to normalize sexual history is to include it in your lifestyle question. Like I always say, look, I'm going to ask you a few questions that I usually ask all my patients. So, when you frame it this way, as I mentioned, like you reduce your stigma, encourage honesty, you make safer, more informed clinical decision. Really important here, yeah? So now with the next slide, so sexual history. So when you're taking a sexual history, especially in general practice, I always tell people like, like for me, I have a clear gynecological framework. Like you can make up a template or something or a shortcut. This is so important so that nothing important is missed. So I usually start with menstrual history. You ask about the usual cycle patterns, the flow, the regularity. Red flags should always be explored. You want to know intramenstrual bleeding, postcoital bleeding, postmenopausal bleeding. Don't forget dysmenorrhea, dyspareunia, which can significantly impact quality of life. Then you go with contraception. You can ask the patient, are you thinking of using something? Are you using anything? Are you consistent? Does it suit their need at that stage of their life? Then you go through a past gynecological history, conditions, ovarian cysts, PCOS, any previous gynecological surgery. Now, all this is important because it completely changed risk assessment and management. Always ask about cervical screening history. When it was last done, were the results normal? Cover a bit of your obstetric history, pregnancy, births, complication. Then you just ask, any other background history. So when you go in a structured approach, you keep the consultation safe, efficient, and patient-centered. Now, for male patient, I'll just add on, do you have any discharge, any dysuria, ulcers, rashes, pain? Talk about erectile dysfunction. Again, normalize it. Libido changes, any ejaculation issues. The next slide. Now, I'm a bit passionate about this slide. So if you Google up in gender bias survey, you can actually read the whole survey. Now, we need to talk about this uncomfortable truth. Now, in that survey, it says that 2/3 of women report feeling unheard or dismissed by their GP. And women are twice as likely as men to feel dismissed by a doctor. Now, for many, this dismissal doesn't look dramatic. It actually sounds quite familiar. It sounds quite subtle. Being told that pain is in your imagination. Yeah, this is normal. You just have low pain tolerance, or their symptoms are simply due to stress. Now, these words really matter. Okay, they don't just minimize symptoms, they delay diagnosis, they erode trust, they teach patients to stop advocating for themselves. So we see the consequences later. Okay, endometriosis diagnosed years too late, autoimmune disease miss, mental health suffering, alongside with physical symptoms. Now, as GP, our power is not just investigation and referral, it's listening, validating, and believing. Now, when we don't have answers, acknowledging a patient's experience just changes the whole perspective of their care. Sometimes, I run out of words and I just say that I hear you, and that's all matters. Okay, so I'll probably move to the next slide. Now, when you actually discuss sexual health, okay, we must always lead with safety and comfort. How you start the conversation will determine whether a patient will open up or shut down. Normalize early. I usually normalize early, signpost clearly. I always say, lots of patients experience this. It's quite a routine part of healthcare. Now that again, that one sentence will reduce shame and reassure patients that they're not alone. Confidentiality, as Rohan said, should be explained upfront, especially for our younger patients, because understanding privacy is so essential for honest disclosure. The trust is built through transparency. I always explain why I'm asking this question. I always say that, look, I'm asking this question because your answer will determine when is the testing, what testing should I do, and everyone is asked question and ask the same question, and some questions will feel personal. And of course, always ask for explicit consent, offer a chaperone, explain that, the chaperone is actually for patients' comfort and safety, not because of suspicion and discomfort. Finally, of course, you reassure them that STI is quite common. Many have symptoms. Most are actually quite easily treatable. So when the patient feels safe, informed, respected, they engage. That's really important. Now, what's really one thing that I stress all the time is that, as an IMG doctor, no matter what your background is, no matter what your religion is, no matter what your faith or personal beliefs are, you leave them at the consult room door. So the moment you walk into that room, you are not there as an individual with opinions, you are a GP. Now, being a GP means practicing medicine without judgment, without assumption, without allowing your personal belief to influence care. Now, Our patients don't come to us to be assessed morally. They come to be treated medically, safely, and respectfully. They deserve evidence-based care. They deserve clear information and advocacy in their best interest, not ours. So that doesn't mean that you have to abandon who you are. It means understanding that professionalism requires boundaries, and it means recognizing that our role is not to direct choices, but to support informed choice. Okay, because that one moment when a patient feels judged, they will stop being honest. And when honesty is lost, safety is lost. All right, we'll just move on to the next slide. This is just a simple example, like some patients get very embarrassed, like when they come back with chlamydia positive. So I always say, look, it's okay. People of all ages get background, like of all background get STI. Doesn't say anything about you as a person. Just let's get you sorted here. This is what I recommend. Or, I thank them for being responsible for, even coming for an STI check. Now, the next slide would be, So for, so the language, So for a lot of IMG doctors that are working, we've worked across cultures. Language is, in sexual health is very crucial. How people define sex is different. So it's really important to have clear, neutral, inclusive language. And, like, for example, like I say that when I ask about sex, I'm asking if you have, I'm talking about any sexual contact. And again, I normalize it by saying, I ask everyone the same question. So, like you always allow the patient to clarify in their own word. You avoid assumptions about partners. I don't say, do you have a husband or do you have a boyfriend? I always ask, do you have a partner? What types of sexual contact do you have? And let patient talk. Now, the next slide. So we might just touch this a bit. So now this is really important, especially for our overseas doctors. So for doctors, especially doctors working in like IMG doctors working in Australia, asking a patient about their Aboriginal or Torres Strait Island status is both clinically and culturally It's our clinical and cultural responsibility. So it ensures the care and services you provide are safe, effective, and culturally respectful. You can ask neutral, respectful questions, like we ask all patients whether they identify as Aboriginal or Torres Strait Islander patient. And this helps us make sure the care and support we provide meets your needs and are culturally appropriate. Then you record. What accurate recording is really important because it's for data quality. So it's really important because we can provide communities with timely, relevant health information and, monitor, evaluate our health outcomes, programs, and funding. Now, for our IMG doctors, the key is to ask without assumption or judgment. You normalize the question again, you reassure confidentiality, and doing so will improve trust, health equity, and ensure that all patients receive care that respects their culture and identity. So, like you do this for every client. So regardless of their appearance, regardless of their country of birth, whether the staff know them or their family background. Okay, so this will avoid assumptions and also ensure equity. Probably go to the next slide. Yeah. So now this is quite interesting. So we've got a 22-year-old female, Hannah, with a possible pregnancy, mouth sores. She's a known patient since childhood, sexually active with a regular male partner for the last 12 months and a brief breakup 6 months ago. And last period was a while ago. Now think, what's your plan? How will you frame this consult? What are the issues here? So the first thing is that, of course, you want to establish pregnancy, yeah? So you can establish, using your urine pregnancy test, that's your office test, or a beta HCG or ultrasound. And then, like, I'm just cutting short. I mean, I'm sure that, there'll be a lot of questions we want to ask, but I'm just going to go with what's really important here. So the further history, I want to know about the sore. like duration, onset, how did it start to look like at the beginning? First of all, make sure, is it an ulcer, is it a vesicle, and then talk about, maybe just ask her, have she had this before? Has she been diagnosed with anything before? And then you want to examine the mouth, you want to examine the lymph nodes, genitals with, chaperone and consent, and the skin for rash as well. Then you can also think about antenatal bloods, all your antenatal bloods, including, STI screening, other screening like chlamydia, gonorrhea, syphilis, HIV, Hep C, depending on the sexual history and symptoms. And of course, the next one would be, swabs. So what are you going to swab? Like let's presume this patient has let's stop there. What are we going to do with the swabs? What swabs are we going to take? So I'm assuming here down the patient, of course, that sore has been there for about 2 weeks. I'm thinking of syphilis. Okay. So what swabs we are going to take? So the first thing you need to do is swab from the base of any ulcer using a PCR swab. Okay. Now, the second thing is, of course, syphilis serology. Sorry, you can also do a PCR, for HSV as well. And then, syphilis serology, and the diagnosis is done in combination of serology, PCR of the lesion, history, and of course, clinical assessment. Now, let's say if it's positive, don't panic. Now, as I said, like I've only seen one syphilis in pregnancy all this while. So, like, don't panic. If you don't know what to do or you don't know how to interpret the results, you contact your local public health unit and seek help. Okay. So here, I think, of course, like you want to get the regular male partner in and test him and treat him. Okay. So, yeah. So as I said, like if it's positive, pregnant women always seek urgent specialist advice. Now we'll probably go with the next slide. Okay, quiz time. So Hannah is 12 weeks pregnant on dating scan. Now, how often would you test Hannah, okay, for syphilis during this pregnancy?
Got lots of answers coming in for you, Maha.
Okay, I'm trying to look at it.
Leave it open just a little while longer. People want
Yep.
to answer.
Okay, excellent. So, so everyone paid attention to Rohan in the beginning. So 3 times, yes, because she's high risk of reinfection. So at booking, booking in 28 and 36 weeks. So here Hannah has issues in that screening period. So yeah, so that's the correct answer. Now, yes, so we'll probably move to the next slide. So now how we're going to start talking about contraception. Okay, so when you open the conversation about contraception, you always create a safe, non-judgmental environment. So you assess the knowledge and the past experience. You can ask the patient, what do you know about different contraception methods available? Have you used any contraception before? What type? How did it go for you? Any side effects, any satisfaction with it, difficulties? Was there excess issues? Was there any problem with cost or, clinic availability, those kind of things? Then you can also go on to start narrowing it down. So what's important to you right now regarding the contraception? So this part here, you're thinking, the pregnancy intention, lifestyle, health conditions, those kind of things. And then you can move on to trying to clarify the information and address the misinformation. So, like an example is like, you can say, look, some people think the pill causes infertility, but evidence shows fertility returns quickly after stopping. So, that opens a bit of conversation. Always provide evidence-based, culturally sensitive guidance. You can give written resources or point them to any reliable websites if appropriate. Then, like I always ask them, like who else is involved in this decision about contraception? So that's really important. So, and the last one, of course, you want to screen for reproductive cohesion. So sometimes partners, you can say that, look, sometimes partners and family may try to control contraception or pregnancy decision. Has anyone pressured you about this? So you want to look for these signs, yeah? So if the patient is missing pills due to partner interference, or, if there's any pressure to use or avoid contraception, or sometimes fear of attending appointments alone. So this is where you can pick up a lot of things as well. I always screen for domestic violence during this conversation. Now, and of course, then you can just summarize. And if we move on to the next slide, you want to explore the motivation and fertility intentions early. So recognize that, like many patients are unsure about timing of pregnancy. So I always say that, are you thinking about becoming pregnant in the next year? So when you use motivational technique of interviewing, you can actually approach the goals and values without any judgment. Then, you can ask like, does the patient want to avoid, delay, or achieve pregnancy? So again, that will guide you into a consult, whether this is a contraception consult, or preconception counseling. Now, then you can also say, would you like to become pregnant in the next year? But as I said, as this slide says, mixed results in primary care, but it can actually prompt meaningful conversation. Now, if we move on to the next slide, so as I mentioned earlier, how to narrow down. So I always give that option. What do you know about contraception? What matters to you the most? So you give a brief overview of all relevant options, especially if the patient wants to see a full range. Okay. And then you can, you talk about Implanon, Mirena, all those things. Then you start narrowing down. So you aim to focus 2 to 3 methods quickly that matches the patient's priority, like the effectiveness, convenience, health, lifestyle. So this allows more detailed discussion. Then you can talk about the pros, the cons, the practical consideration around this. Now, if let's say the patient is presenting for a specific need, for example, if the patient comes up and say, oh, I'm just here for a repeat of my pill script. So you can check the knowledge of the chosen method, and, you can offer additional information or other options, if they want to talk about it, keeping the patient informed, but don't overwhelm them. Okay, then you can move on to like shared decision. So as we spoke about discussions of pros, cons, side effects, lifetime fit, then you incorporate patients' motivation. What's their fertility intention? What's their, is there someone talking to them, asking them to do this? So then you make that decision together. And once the decision has been made, it has been started, you always follow back. You can give them the information, hand them paperwork and say, why don't you decide and come back? Or, sometimes you just have to do the quick start method. So again, you work together with the patient in all of this. Okay, so if you move on to the next step, next slide. So think of what are the important factors when people are choosing a contraception method, so what do you think? Just think for a while. What are the most common things that, patients decide when they want to think about, starting contraception? So of course, efficacy, like how reliable is the method to prevent pregnancy? Then you want to think about bleeding impact, how are the methods, this choice of contraception going to affect my menstrual pattern? Is it going to be heavier? Is it going to be lighter? Is it going to be irregular, absent periods, those kind of things. Then you also have to think about medical conditions, the safety consideration, thinking on the other health issues like patients with hypertension, which would be suitable, patients with clotting disorder, patients with migraines with aura, those kind of things. And then you also some patients think about non-contraceptive advantages, like this might help me reduce cramps, this might make my acne feel better, look better, and also protection against certain cancers. Then you think about other things like age, reproductive stage, the patient's fertility goals. Is the patient perimenopausal or is it postpartum? These things will influence choices. And of course, you want to think about patients think about, the access to it, cost, oh, I want a Mirena, who's inserting it, how much is it going to cost? So, and the convenience of obtaining that certain method. I see a lot of patients that are influenced by others. Oh, my friend has a Mirena, or my friend has an Implanon, so influence of others, like especially from partners, from family, from friends, that they can affect our decision making. So, yeah, and ethical and of course spiritual belief, what does their personal belief, cultural or religious values, that will guide what methods are being acceptable. All right. So finally, this is just a review, like you talk about the contraceptive options, then you move on to discuss method specific issues, as I mentioned just now. Then you don't bombard them or throw everything to them. You allow time, for questions. You provide, I usually use from Family Planning New South Wales. You can always give them printed material according to their language, according to their literacy level. And then, of course, then you move on, like plan, like, for example, if you want to do a Mirena insertion, you plan or you refer or you insert, one of it. I'm not going to go into the quick start method. We all know what is it, but, that's when the next step comes in. All right.
Thank you so much. I don't think we've ever finished on time. You guys are amazing. Now, if there's anybody who has any burning questions, feel free to put them in the Q&A box. But I might just start out with asking some questions about, both of you, in terms of working in Australia. What have been the differences between working in your home countries and working in Australia in sexual health, reproductive health? Can you chat about maybe some of the interesting things, the challenging things that you've come across?
All right, maybe I go first. I think I'll give you an example, Natasha. When I was a training, I saw a case where a man in his 40s, executive, has a wife and two young kids, who went to multiple doctors, GP specialists with a sore eye, and ended up getting blind on one eye. They ended up having nephrotic syndrome and had biopsies. And after multiple consultations, ended up in eye hospital in Sydney, ended up having syphilis in the eye. And nobody took a sexual history. These are not just general practice, these are specialists one after the other. And he ended up having syphilis and HIV. And when you talk to him, he occasionally go overseas, have sex with men. Because we assume he has a wife and two young kids, he do an executive job in a suit. I think there's sort of assumptions that we make. We always do that. I think when you come to sexual health, if you leave these assumptions out and say that I'm going to ask these questions because that is in the deficient diagnosis. So one thing I think getting my head around that is actually easy when you start to think about that. You leave your like judgments, your values, your religion, what you say, and how you upbringing. You just make it as a normalized. I'm going to ask everybody if this patient come to me with a red eye, if I have a slightest doubt, this could be syphilis. I'm not going to have that assumption that he is a man in a suit with a wife and a kid.
Yeah.
So I think that's something always stays with me throughout my career.
And was it different in your home country dealing with that? Or did you feel like
It's extremely different. It's very different because it's not talked about. And also the stigma and the judgment. I think one thing here is because the health service is we get learned about this. Here in even in med school back home in Sri Lanka, we have a very little. Now we talk about sex and
Yeah.
it's a taboo topic and we don't get learned. I think the understanding that we can learn and we can get trained, and if you're not good at it, you can practice and you can seek help.
Yeah, of course. And Maha, what about you?
So I think one thing that I remember the most is that when I was in ED and back home in Malaysia, like this girl came in, she was 8 centimeter dilated, she's pregnant and kept denying that she had sex. Like, and the moment like she delivered the baby, like they were hitting her because, like, and I mean, she's young, she's 17, but it's something that, it's not spoken about, like we've got such a big population, everybody has sex, like, but it's something that is never spoken because it's a stigma, like, and, like, for example, I don't think when I was doing my internship, a sexual chat, even in the OBG department, like, are you okay? How is sex? Are you experiencing it? Nothing. There was no discussion, and I remember I was quite rebellious, like for an Asian girl to go and ask, is sex painful? Like, and it's so important because it tells us so much. And, like, I find that till only now, slowly, I have seen myself back home and even in Australia, and that's why I talk about this a lot. I have seen doctors who judge you so fast, like they go like, oh, okay, yeah, right, STI. You cannot do that. So patients won't come back. And I get that back home quite a bit. The judgment, the stigma is still there.
Yeah, and it's all relative because I mean, I think we, even as Australian trained doctors, there's a lot missing in our education and feeling prepared to take sexual histories. It's across board, it's getting better, but it's interesting. I mean, it can be the same here, right? Somebody in the chat box just mentioned that there's no difference in the terms of taking sexual histories, but the language can be quite difficult. Do you have any advice around that? I mean, Rohan, that was great, some of the language that you taught us tonight, but or any resources, maybe general resources as well.
Yeah, I think sometimes I think using the anatomy, so it's a part of the body, right? Think as if I'm describing something in my face, I think use the same thing. It is a part of the body. Use the anatomy and also use like a picture. Sometimes in my consult rooms, I have pictures, I have some models, and I showed the patient point where things are. Particularly sometimes conversations might not gonna go very well and they're embarrassed to for the examination. I would say draw me, show me where things. I think if you use the anatomical term, it makes it a lot easier. And I think this is a part of the body.
Yeah.
Yeah. And I also think that, like, there's nothing to be hidden, like, as I said in my slide, if you are nervous, they will feel it. They will be like, oh, should I say something? Should I not? So, like, just ask directly, are you having sex?
Yeah.
Like, are you insertive or are you receiving? Normalize the language. There's no correct language. For me, I feel English easy, ask directly. Like, and but I always reassure confidentiality, and I always said, look, if you don't feel comfortable, you don't have to tell me. You can tell me later when you feel comfortable. You reassure that, and then you say that it stays confidential. So you create that space and then you just use your normal language, like, yeah. So I've come to a point where my patients come in and say, oh, Dr. Maha, I've got chlamydia again. I don't even have to ask, like, and they were like, oh yeah, I know, like it will normalize along the way.
Yeah, and I think using the same language that the patient uses sometimes, because even there are a lot of people that don't know their own anatomy either, and so I think sometimes using and educating the patient, but it's a great point. There were some questions. I know we're about to finish up, but there were some questions about resources. We're going to send you quite a few resources and links and websites to those of you who've signed up to the webinar. So don't worry, there'll be lots of great info there that, if you do have an interest in this or want to learn more, there will definitely be some great points of contact that you can look at. But I